We now have a session on epilepsy and other disorders of consciousness, when the brain screams in silence. This is the last pre-lunch session. Chairing this session, we have Dr. Vijay Arora, sir. He is the Director and HOD of Department of Internal Medicine in Max Super Speciality Hospital, Patparganj. He is an alumni of PGIMS Rohtak. We also have Dr. Sharat Johri, sir. He is the professor in the Department of Neurology in SRMS Bareilly. Sir is an alumni of AIMS, AMU and R&R Hospital. He has more than 20 publications to his name. We also have Dr. Surekha Dabla, ma'am. Ma'am is the HOD of Neurology in PGIMS Rohtak. Ma'am did her DM Neurology from AIMS. Her areas of interest include stroke, epilepsy, and multiple sclerosis. I welcome our chairpersons and request the chairpersons to kindly introduce our speakers and start this session.
Good afternoon. Dr. Gagandeep sir is presenting. Sir is a professor and head Department of Neurology at DMC Ludhiana, India. Sorry, I can't read. Sir is a fellow of Royal College of Physicians, and he is fellow of various academic councils, and he has various affiliations. So I invited Dr. Gagandeep sir for his talk, and it is when enough is not enough, novel treatment for refractory and super refractory status epilepticus.
Thank you, dear chairpersons. At the outset, I must thank the organizers, Dr. Arun and Atmaram. Thank you for inviting me, and thank you for asking me to talk on this topic. It's about novel treatments for refractory and super refractory status epilepticus. When enough is enough, when do you call it a day? My counter to that is the word is not enough. You know, there is a limitless field, and we should just keep trying. And I think that should be our motto, and that should be what we should be doing. So this is a historical vignette. The King of England, he fell down, had a violent convulsion. King Charles, this was the 16th century. And this is the kind of treatment that was given. Clearly, the king was in status epilepticus. And a pint of blood was taken, his shoulder was incised, then he was given an emetic, purgative, some enemas were repeated. All these kinds of treatment were given, not to the surprise of anyone or everyone sitting in this hall. The treatment failed and the king succumbed to the status epilepticus. Fortunately, we have better treatments now, and we have good treatments, and this kind of thing does occur, but it does not occur that often. Another historical article, and which is very well quoted and very well read, and this provides a list of treatments that have been used in status epilepticus and refractory status epilepticus. So you see, anything and everything under the sun has been used to treat status epilepticus. It is that kind of situation. It is the extreme manifestation of epilepsy. And in this condition, our management goals are, of course, one, the termination of status epilepticus. Once the status is terminated, it's important that the patient should not have more seizures, so prevention of seizure recurrence. There are a number of underlying causes for status epilepticus, as you would all know, and therefore it's important to treat the underlying cause, whether tumor, trauma, or stroke, or whatever. And then there are a whole lot of complications which can occur in status epilepticus and the treatment of status epilepticus, and it's an important management goal to prevent and to treat these complications. Refractory status epilepticus, as you would all know, there is a time period which is arbitrary. There is actually an explanation for that, and I'll come to that. Is 24 hours. So beyond 24 hours, refractory status epilepticus is beyond 30 minutes, and super refractory status epilepticus is beyond 24 hours. So once Now, there is enough consensus and expert opinion. Once the patient crosses 30 minutes and we label the patient as having refractory status epilepticus, we need to move on from anti-seizure medications to intravenous anesthetic agents. And the choice that we have is from these three: propofol, thiopentone, and midazolam. And quite often, when one does not succeed, we go on to the other, and this kind of thing is repeated. Now, I've put up this study here just to demonstrate how difficult it is to do trials in status epilepticus. This was a randomized treatment trial for status epilepticus, which which compared barbiturates with propofol. And after 3 years, this trial was terminated because they just could not get enough patients. So, ladies and gentlemen, what I want to say is it can be really difficult to do trials in status epilepticus, and particularly refractory status epilepticus. And many of the trials which have been done so far had to be abandoned because of various reasons. This is a Cochrane review, which basically now we have these three drugs. We have propofol, we have intravenous midazolam, and we have thiopentone or pentobarbital. So we don't have good evidence. We do not have level 1 evidence. We do not have class 1 evidence. We do not have good randomized control trials. What we have are small series of cases. Some of them would be comparative series of cases or open label kind of trials. And this Cochrane review really found no difference between the efficacy of thiopentone and propofol. Their side effects were similar, and there were no major differences in terms of efficacy between these drugs. So, this is actually a little bit of pathophysiology, going into a little bit of pathophysiology. See what happens. The green triangles are the receptors for the GABA, and the red ones are the receptors for NMDA. And what happens as the status epilepticus progresses, the green ones or the GABA receptors get internalized, right? And the NMDA receptors start getting externalized. NMDA receptors, you know that mediate excitotoxicity and are toxic for the neurons. So what happens is, as time progresses, the efficacy of all the GABAergic drugs, benzodiazepines and other anticonvulsants, goes on decreasing, and there is excitotoxic damage, right? So this is the reason why it is stressed that treatment should begin early. Drugs are likely to be effective if given early, and are unlikely to be effective if given late in treatment. That's the time window of treatment of status epilepticus, and it's extremely important to understand that. But there is some hope in this, because you see, it is the NMDA receptors which are coming, right? And we know that ketamine is an NMDA receptor antagonist, and therefore there is this option of giving ketamine in patients with status epilepticus, and this is the theoretical premise for administration of ketamine in status epilepticus. This is a paper, it's actually an old paper by David Freeman. These are the EEG stages of status epilepticus. You have discrete seizures, you have merging seizures, you have continuous ictal activity, and then you could have something like a burst suppression, and then finally you have generalized periodic epileptiform discharges. So these are the various stages of status epilepticus, going from early to late, going from mild to severe, and going from in terms of prognosis, going from a good prognosis to a bad prognosis. So EEG of a patient showing PLEDs, and then you have a seizure which is coming from the right temporal. You see the seizure builds up and then it stops. So this is the stage of discrete seizures. As opposed to the stage of multiple seizures or merging seizures or continuous seizures, where the activity would look something like this. which eventually becomes slow and stops at some stage. And then you have these generalized periodic epileptiform discharges, which is basically a dismal situation. There is, in this kind of situation, you can say that enough is enough and we don't really want to do much because there is nothing much that can be done in this kind of situation. And last but not the least is the phenomenon of burst suppression, which is actually drug induced. And you can see that these are periods of alternating suppression with bursts of activity. And this is actually one of the useful targets while administrating intravenous anesthetic agents in status epilepticus. So this is interesting study which was published recently, which looked at, which was actually a retrospective study and which looked at comparison of outcome in people in whom burst suppression was achieved versus those in whom burst suppression was not achieved. So this is actually the difference. Breakthrough seizures, that is seizures occurring as long as the intravenous anesthetic agent was given, were much less when you achieved burst suppression. But after burst suppression, after stopping the intravenous anesthetic agent, the chances of withdrawal seizures were actually much more. The other outcomes, whether it is mortality or long-term functional outcome, was actually not different between patients in whom burst suppression was achieved and patients in whom burst suppression was not achieved. Now, I showed you some burst suppressions, and this is also another example of burst suppression, but it is slightly different from the earlier ones. And you can see that there is some kind of epileptiform activity within the burst suppression. And I think once you are able to identify this kind of epileptiform activity, this is not a good prognosis. You know, the other kind of burst suppression which I had shown, there was no epileptiform activity, but this contains some epileptiform activity. And once this kind of activity is there, this is not a good sign, I think. On the EEG, this is not a good sign. The chances of breakthrough seizures are very, very high. The chances of withdrawal seizures are very high, and chances of achieving a remission are extremely low. And indeed, it is this kind of finding has been demonstrated in this particular paper, which clearly says, I've highlighted it in red, the amount of epileptiform activity in bursts correlated with the success or failure of weaning the intravenous anesthetic treatment. So these are subtle kind of markers which can tell whether your treatments, your intravenous anesthetics are going to succeed or not succeed. The difference between the discharges, the epileptiform discharges, and the bursts are quite clear. Bursts are prolonged, you know, and they have multiple phases, as opposed to discharges which would have few phases and they would look like any other kind of epileptiform discharge. This is another trial. I said not many trials in refractory status epilepticus have been done, and whatever trials have been done, many of them have been abandoned. And this is another example of a trial which was abandoned, where valproate was actually combined with phenytoin. And perhaps they didn't get enough patients, or there were some ethical issues, and this was abandoned. Coming to ketamine, right? So there is, again, these two trials of ketamine. Their protocols were published in literature, but eventually these trials never saw the light of the day, and they had to be again abandoned. This is something which was actually done, and it saw the light of the day. It was eventually published. But in patients with cardiac arrest, you frequently see this kind of periodic patterns, activities, whether they are generalized discharges or focal discharges, hemispherical discharges. The question is, do we try to suppress them with intravenous anesthetic agents and anticonvulsants? And clearly, the editorial that accompanied this paper, which was titled "Futility of Suppressing Seizure-like Activity in Post-Resuscitation Coma," clearly tells us what was the outcome of this particular trial. So no luck here either. Lastly, about ketamine, which I know is being frequently used, and I think it's an excellent drug. We have tried it in a number of patients, probably more than 25 patients over the last 5 years or so, and we think it is a very effective drug. And in this study, what this systematic review, ketamine was found to be more effective if it was administered early. So the current trend is try all these intravenous anesthetic agents, try propofol, try intravenous midazolam, try thiopentone, and when none of these work, then go over to ketamine. But this particular systematic review suggested that ketamine is useful early on, and it should be tried probably much early on. A few words about the pharmacology of ketamine. It was the molecule was found in the 1960s. It was a derivative of phencyclidine, and very interestingly, there is an oral form of ketamine available also, and that has been indeed tried in status epilepticus. Ketamine is also used, both oral and intravenous form, in patients with treatment-resistant depression. And of course, we know that it is an anesthetic agent with profound analgesic effect. It causes dissociative anesthesia. It is safe in hepatic and renal disease. The mechanism of action, I showed you that cartoon where you had the NMDA receptors which were coming in late. So ketamine acts on the NMDA receptors, and that is why, I mean, it offers two kinds of hope for me. One is it is useful once all the GABAergic receptors have been depleted. And the second is NMDA receptor encephalitis, which often may present with status epilepticus, and ketamine might be a very good drug in that kind of situation. Of course, the other advantage is that the respiratory depression and the cardiovascular depression associated with ketamine are minimal. It does have psychedelic effects, hallucinations, and so on and so forth. And therefore, it is important to administer it along with midazolam. Because it acts on the NMDA receptors, so there is a potential for neurotoxicity, and therefore we should keep that in mind. Another issue is using multiple types of intravenous anesthetics, so a combination of propofol and midazolam. And sometimes in our patients, when single agents don't work, we have tried multiple agents. Only thing I have to say is it does lead to more and more adverse effects and side effects. The ketogenic diet, I think it has been tried much more often in children, but we've tried it in adults also. It has an odd case, I think, has responded very well, and this is some literature both in children and adults. It does produce seizure resolution in a number of cases, but there are side effects. Inhalational anesthetics. So there is a whole lot of inhalational anesthetics, including halothane, which we know can be very toxic to the liver and the kidneys. But there are other agents like enflurane, desflurane, serviflurane. Some of them might actually enhance the epileptiform activity. But the problem with using these drugs is that you need to get the anesthesia machine which is used in the theaters into the ICU. Right, it is supposed to have a vaporizer, so that equipment needs to be moved in the ICU. There are two things, you know, in an odd patient, when we had very prolonged patients with status epilepticus, we discussed this with our anesthetics thetist, whether we should be using or whether we can try inhalational anesthetics in these patients. The problem is I see two problems in our setup. One is it requires a continuous monitoring per patient by an anesthetist. So that becomes technically very difficult. And secondly, this gas is going to be released in the ICU environment. It might be toxic to the doctors and the other patients there. So these are some of the issues with the inhalational anesthetics. We have this entity, NORS and FIRES, and there is a beautiful paper just published in the ILE recommendations for investigation and treatment of NORS, which is new onset refractory status epilepticus, and FIRES, which is febrile infection related. FIRES is a type of NORS. Any new onset de novo status epilepticus would be referred to as NORS. Remember that there is a difference between the two. And what is the difference between the two? NORS, the chances Dr. Sudhiran was discussing autoantibodies, the chances of finding antibodies in NORS is quite high, reasonably high, sub 30%. But in fires, these patients generally do not have antibodies and they do not respond very well to immunotherapy. So this is the difference, and there are actually some scales by which, some clinical markers by which we can say that this particular status, new onset status epilepticus, has an autoimmune basis, and we should institute. In fact, this new paper published in Epilepsy, which has just been published a couple of days ago, clearly says that you need to institute immunological treatment, either steroids, IVIG, or plasmapheresis within 72 hours of onset of status epilepticus. So the trend is to start immunological treatments, to start steroids very early in patients with refractory status epilepticus. So these are some of the newer agents, some of the newer treatments for status epilepticus, the problems with them, the problems with conducting trials in patients with status epilepticus. I will stop here. Questions would be later.
Thank you, sir. Dr. Manjari is there. So now we will proceed on to our next.
Good afternoon, ladies and gentlemen. Our next session will be by Professor Kurian Thomas, and he'll be telling us the approach to patient presenting as rapidly progressive alteration in consciousness and coma. Professor Kurian.
Good afternoon, everyone. I would first like to thank Dr. Arun Garg, Dr. Rishu, and the entire organizing team for giving me a chance to talk in this forum. So today's talk is on approach to rapidly progressive altered sensorium and coma. This is a common problem that is faced by all neurologists in our day-to-day practice. Consciousness has two components. One is the content of consciousness, which is subserved by the cerebral cortex. So your awareness of self is what is referred to as by the content of consciousness. Arousal refers to the level of alertness, and this is maintained by the ascending reticular activating system. Impairment of arousal can vary from drowsiness to coma. Delirium, the terminology, was first used by Celsus, but it was described much beforehand even by Hippocrates as phrenitis. Often these two terminologies are used interchangeably, delirium and encephalopathy. Delirium refers to the acute mental change which is characterized by abnormal and fluctuating attention, whereas encephalopathy is any altered consciousness presenting for longer than 24 hours. So the patient might present to you with irritability or just a change in personality or behavior. Encephalopathy and encephalitis, are they one and the same? In encephalopathy, there is no CNS inflammation. So you do a CSF analysis, it is normal. But in encephalitis, there is encephalopathy along with evidence of CNS inflammation. So this might be in the form of fever, seizure and focal neurological deficits, or CSF, EEG and MRI, which show an evidence of CNS inflammation. Encephalitis is a neurological emergency, and when you approach a patient with encephalitis, many a time MRI is the thing that gives you the clue for an appropriate diagnosis. Because we depend on the history from the patient for majority of the situations, and a patient with encephalitis himself or herself is not able to give you the history. So like we already discussed, a depressed level of consciousness can be due to an impairment of the ascending reticular activating system, which leads to impaired arousal, or it can be due to bilateral cortical involvement, which leads to impaired awareness. So there is diffuse neuronal dysfunction in a patient with encephalopathy. These can be broadly divided into structural causes and non-structural causes. So you see any patient with encephalopathy, first thing that you should identify is it structural? Because if it is structural, you require an early and urgent imaging because it might be due to a reversible cause. So asymmetrical neurological findings like anisocoria, hemiparesis, asymmetrical eye movements, these will help you to say that this is due to a structural cause. Non-structural causes like toxic and metabolic causes, the patient will have symmetrical neurological findings. This is not always the norm. You can have structural causes involving the brainstem, etc., where the patient presents with symmetrical neurological findings. You have some people who are predisposed for delirium. Elderly patients, immunocompromised individuals, patients with renal and liver dysfunction, etc. And also, in a patient, you can even precipitate delirium. There can be iatrogenic precipitants. So you have an elderly patient who is admitted to the ICU who undergoes a catheterization, or you add more than 3 medications in a period of 24 hours. These are non-iatrogenic precipitants that can precipitate delirium. Coming to the etiology of rapidly progressive altered sensorium, this should be approached on the basis of structural causes and non-structural causes. So structural causes can be trauma, tumor, vascular causes like stroke, which should be identified early because you have an early and efficient management for the same, encephalitis, seizures, and other situations like PRES, osmotic demyelination syndromes, etc. Encephalitis can be due to infectious causes or non-infectious causes. So most commonly you have the viral encephalitis, and in the non-infectious causes we have the autoimmune encephalitis and Hashimoto's encephalopathy and the non-convulsive status epilepticus spectrum disorders. Like I mentioned already, not always you have structural causes presenting with focal neurological deficits. So these are some common situations where you have vascular events and the patient is presenting only with altered sensorium. An artery of pressure on infarct leading to bilateral thalamic infarcts, venous infarcts in a deep CVT, bilateral watershed territory infarcts in a patient with diffuse vasculopathy, and a non-dominant parietal lobe infarcts. All of these patients might present to you with altered sensorium alone. Metabolic causes and toxic causes. This can be due to endogenous derangement, like in a patient who has got an uncontrolled hypertension, hypoglycemia, or a dyselectrolytemia, or due to exogenous causes like alcohol abuse, toxin use, drug use like methotrexate and other chemotherapeutic agents. How do you approach such a condition with such a vast variety of causes? Any patient with altered sensorium you see, the first step is to stabilize the patient. So you can go with the ABCDE approach. Check the airway, make sure the airway and breathing is okay, check the circulatory parameters, assess the patient for neurological deficits with a Glasgow Coma scale, look at the pupil, look for brainstem reflexes. If there is a pupillary asymmetry or there are brainstem reflexes are impaired, go for early imaging to identify structural causes that might be causing a raised intracranial pressure. Expose the patient and look for any evidence of infection that might be with subtle seizures or with rashes that might be present. One important thing that I want to mention here is that in such a patient, there is a chance that he might develop a Wernicke's encephalopathy. So if you have a patient with altered sensorium, he might not always be an alcoholic. You have a patient, a pregnant lady with hyperemesis gravidarum. You have a malnourished individual, a patient on total parenteral nutrition. Such a patient presents with altered sensorium. You should always administer thiamine, and especially before you administer glucose, because administration of glucose without administering thiamine can precipitate a Wernicke's encephalopathy in such a patient. Look at the breathing patterns, and this has a role in management also. If a patient has a medullary involvement causing agonal breathing patterns, you might need to go for early elective mechanical intubation. A careful history is important. The main thing is ask and assess for history of infection, ask for history of seizures. These will help you to identify structural causes fast. There are some specific history that will help you to identify infectious causes, like a patient who is working in waterlogged areas. He is prone for leptospirosis. Is there a history of travel to areas endemic for conditions like rickettsial encephalitis? A history of recent vaccination might lead to ADEM, presenting with altered sensorium. Assess the patient's vitals. Tachycardia might be the only manifestation of sepsis, sometimes in an immunocompromised individual. In the same way, bradycardia and hypertension might be your only clue to pick up a patient with a raised intracranial lesion which is manifesting as a Cushing's reflex. The general and the systemic examination might throw valuable clues. Skin rashes are something that will help you to identify conditions that are causing altered sensorium. So in the first picture, you have a herpes labialis rash where you have the typical grouped vesicular eruptions which can turn pustular later. You have the vesicular eruptions causing severe pain in a dermatomal distribution in a patient with herpes zoster. This is a classic eschar of a patient with rickettsial disease. And in the last two pictures, the first picture is one of an erythematous ecchymosis. So it is a non-blanching rash which is seen in meningococcal encephalitis, and in the last picture you have an erythematous maculopapular rash which blanches on pressure in a patient with a dengue encephalitis. Many a time, these skin findings might be your only clue to pick up a patient with infective endocarditis who has presented with altered sensorium due to embolic infarcts. So you have Osler's nodes and Janeway lesions. A crisp, detailed neurological examination should be conducted fast, and you should look for signs of meningeal irritation, history of seizures, and also look for movement disorders including Parkinsonism. Identification and early management of seizures is essential. You have some typical seizures like a fatiobrachial dystonic seizures, which might be the only manifestation of LGI encephalitis. Also look for subtle manifestations of seizures like twitching of limbs, eye movements, etc., which may point towards a patient with non-convulsive status epilepticus. When you initially assess the patient only, send off the routine investigations including your blood counts and metabolic parameters. Do an early imaging. MRI is the ideal imaging to be done. CSF analysis, and in conditions where you are suspecting a seizure, EEG should be done. The second line investigations. So if you are doing the first line blood investigations and your MRI does not give you a definitive diagnosis, go for second line investigations, which you should select in the appropriate case. So ammonia levels, B12 levels, autoimmune panel, etc. CSF analysis is key to establish evidence of CNS inflammation. It should be done at the earliest when you are suspecting encephalitis. By chance, there is a reason that the CSF is delayed and you are suspecting a viral encephalitis, always administer acyclovir early, because a delayed administration of acyclovir in a patient with HSV encephalitis can lead to significantly increased mortality rate. CSF should be sent for cell count, other routine investigations. CSF PCR in suspected viral encephalitis. CSF in viral encephalitis shows a lymphocytic pleocytosis with elevated protein and normal glucose. CSF PCR may many a time give you the diagnostic clue. So in HSV encephalitis, 95% of the cases, CSF PCR comes positive. In autoimmune encephalitis, again you have an inflammatory CSF picture. One important thing that I would like to tell is that in around 10% of cases of autoimmune encephalitis, the only abnormality might be the presence of CSF oligoclonal band. You might have normal cell count, normal protein. So sending CSF oligoclonal bands might be a useful thing to pick up in a patient who has presented and you are suspecting autoimmune encephalitis. Now coming to the important part, neuroimaging in altered sensorium. The ideal and the best investigation is an MRI, but many a time your patient might not cooperate for an MRI and you might have to settle for a CT. In patients who have got a history pointing towards a raised intracranial pressure, so a patient with a history of previous brain lesion and immunocompromised patient, always imaging is mandatory. And these are the bare minimum sequences that you should do when you are doing an MRI for a patient with altered sensorium. Some of the diseases have some favorite spots in the brain which are affected. So you have a herpes simplex virus encephalitis which affects medial temporal lobe, orbitofrontal cortex, and the insular cortex and the cingulate gyrus. This is a patient with enterovirus encephalitis. There is no supratentorial involvement. The patient will have involvement of the brainstem and the spinal cord. And in the brainstem, there is a predilection for involvement of the dorsal pons. This is a patient with HIV who has got a subcortical flare hyperintense lesions sparing the subcortical U fibers. Varicella zoster encephalitis has a predilection to involve again the white matter, the cerebellum, and it is known to complicate by causing vasculopathy leading to recurrent strokes. Japanese encephalitis is characterized by symmetrical hyperintensities involving the thalamus with variable diffusion restriction and hemorrhagic conversion. This is a patient with the rabies where there is a predilection for gray matter. You can see the edematous gray matter in addition to the flare hyperintensities involving the lentiform nucleus. This is a typical case of a patient with tubercular meningitis where you have basal exudates which are enhancing on the T1 post-contrast images. Now, we have a 28-year-old male who has presented with a fever and headache. After admission, he has an episode of generalized tonic-clonic seizure. His MRI shows a flare hyperintense lesion which is affecting the medial temporal lobe with subtle diffusion restriction and patchy contrast enhancement. You do an EEG and there are continuous periodic lateralized epileptiform discharges. CSF PCR comes positive for HSV. So this is a typical presentation. In adults, HSV1 is the most common cause of HSV meningoencephalitis. HSV2 usually causes meningoencephalitis in children. When you have a patient with an imaging showing a medial temporal lobe abnormality, are there any differentials for HSV encephalitis? So, in the first picture, you have a patient with the asymmetrical involvement of the medial temporal lobe. And in the second picture, you can see a patient with a paraneoplastic limbic encephalitis. You should note that there is the mass effect and the edema are significantly less. And in the last two pictures, you have a patient with an arterial and a venous infarct. This will respect the arterial territories. So, herpes encephalitis, the patient will have asymmetrical or multifocal involvement of the medial temporal lobe. Typically, the gray matter nuclei will be spared. There can be hemorrhagic changes and patchy contrast enhancement. If you have a low-grade astrocytoma, it is not multifocal. There is a unilateral involvement. There is no significant edema. There is no hemorrhagic change. In a patient with limbic encephalitis, again you have asymmetrical bilateral involvement. In patients with arterial and venous infarcts, you have an acutely presenting patient and the MRI will show that the lesions are respecting the arterial territory. So, we have a second case where a 60-year-old alcoholic lady has presented with altered sensorium. After admission, the patient developed a hemiparesis and a focal status epilepticus. This was the initial MRI, which shows a flare hyperintensities affecting the frontotemporoparital cortex, especially the cortical gyrus are affected. EEG showed an electrographic seizure, and in the interictal period, there were plets. This was a SESA syndrome with non-convulsive status epilepticus. She was managed with multiple anti-epileptic medications and the seizure resolved. But the follow-up MRI showed incomplete resolution of the flare hyperintensities with some atrophy involving the cortex. So if a patient with altered sensorium and there is a history of alcohol use presents to you, what are the differentials that you will consider? You will think of a Wernicke's encephalopathy if your patient has history of confusion, ophthalmoplegia, and ataxia. Alcohol withdrawal seizures and SESA syndrome, it is often difficult to differentiate for the physician. How can we differentiate these two entities? In a patient with alcohol withdrawal seizure, the patient has a generalized tonic-clonic seizures, usually within 48 to 72 hours of alcohol cessation. SESA syndrome, the patient might present with GTCS, focal, or complex partial seizures. Alcohol withdrawal, there will be no focal abnormalities. Seizure syndrome, there will be focal abnormalities and there will be reversible motor deficits. MRI will be normal in alcohol withdrawal, whereas Seizure syndrome, it shows reversible T2 hyperintensities. You don't give long-term anti-epileptic therapy in a patient with alcohol withdrawal seizures, whereas in Seizure syndrome, you require long-term anti-epileptic therapy. If you have a latent period between the onset of the intake of alcohol and the onset of the disease, two things that you should consider are methanol poisoning and again Seizure syndrome. So I will come to a conclusion of my presentation. The management of a patient with acutely presenting altered sensorium is not easy to say in a short period. The main things that you should consider are correct the metabolic derangement, administer thiamine, withdraw any offending drugs that the patient might be on, treat the vascular causes, and in conditions like an immune-mediated or infectious encephalitis, the definitive treatment should be initiated. Time is of essence in a patient with acute encephalitis. Early appropriate treatment can confer significant mortality benefit, as it is shown by a reduction in mortality from 70% to 20% if you administer acyclovir within 6 hours of presentation. So a robust management is of essence because time is brain in more ways than one. Thank you.
Thank you, Dr. Kurian. Now, the last topic is by none other than Dr. Manjari Tripathi. We all know her well. Everybody knows her. That she is a professor in All India Institute of Medical Sciences. She has keen interest in sleep medicine, in tropical neurology, but her passion is epilepsy and epilepsy surgery. She has been she has a fellowship in epilepsy from Los Angeles. She has been secretary of the Indian Epilepsy Society, and she has been actually core member of epilepsy treatment guidelines by the government of India. She is going to tell us that what is not seizures. All unconsciousness, they may not be there. Almost 15 to 20% of the patient who present with seizures may not be having true seizures. She will tell us how to differentiate. Dr. Manjari, please.
Persons and thank you participants and organizers for having me here. It's a long topic, it's a vast topic, so the title is interesting. It was called The Joker with a Mask, I don't know, maybe. So the diagnosis of epilepsy is apparently simple for people who see patients day in and day out, but the best of centers in the world, 25% of people who are so-called labeled as epilepsy don't have epilepsy. And this is because there are many things which look like seizures and epilepsy. So what is epilepsy? Epilepsy is 2 or more unprovoked seizures, okay? So that's epilepsy, or a single seizure with a higher than 60% chance of recurrence based on your imaging, based on your EEG, focal deficits, and family history and mental retardation. So, and of course, if you have reflex seizures, that's epilepsy too. Or you have a syndrome, whether it's absence or whether it's a self-limiting epilepsy syndrome of centrotemporal spikes, etc. So that's epilepsy for you. The diagnosis of epilepsy is essentially a clinical diagnosis. So this is where all clinicians should get excited. It is a clinical diagnosis. It's not something which is rocket science. It involves taking a detailed history of what happened prior to the event, during the event, and after the event, and between 2 or more events. So really, it is something where the history of that episode has to be taken in extreme slow motion. We try to complement the diagnosis by an EEG, and sometimes if seizures are not controlled, then we of course try to do further advanced investigations, whether it's a video EEG, whether it's all the epilepsy protocol MRI, and if it's truly refractory and you really don't have a clear MRI, you often go ahead with further advanced investigations like PET, SPECT, MEG, and SEEG. Now, the first step, even for the best of epileptologists, is that if the seizures are continuing, what could be the reason? And the most important reason, apparently so, is that my diagnosis as an epilepsy specialist is wrong. So let's see what really can go wrong even in the best of centers. So what are these falls and faints, etc.? There's a host of disorders, and we'll see, rush through videos of some. I know I'm standing between you and lunch. It can be syncope. Okay, syncope is very, very common. It's commoner than epilepsy. And we know vasovagal syncope, cardiac syncope, cough syncope, micturition syncope, and of course, what have you, postural syncope. All of it, we see it again and again. And in fact, this is something which really is very, very important. Then, of course, comes, stroke-like events, particularly limb-shaking TIA, which is not uncommon, or it can be a posterior circulation TIA, or it can be a transient global amnesia, where, it's like a transient epileptic amnesia, but it's longer in duration. And it can be drop attacks due to a, colloid cyst in the third ventricle, or it could be a migraine with akathisia, which is seen in cluster headaches, where they get up from sleep and they have extreme restlessness, which can be mistaken as epilepsy, or a migraine of the vestibular posterior system, which is responsible for episodes of altered sensorium. It could also be people with sleep disorders, particularly cataplexy, something which we really, miss out and get labeled as seizures, particularly if the episodes are partial or unilateral. And then you have the parasomnias, where you're walking around in the night, REM sleep behavior disorder, where you're just thrashing around in the night, myoclonus in the sleep, etc. Drugs, not uncommon, very, very common cause, particularly in the elderly. Day in and day out, we see people who have been started on benzodiazepines like clobazam or zolpidem, and they take it and they sleep for 3 hours and they get up in the night and fall. And then they're amnestic about it. So they get labeled as having seizures. What they actually have is the drop attacks because of loss of tone, because of the benzodiazepine. So drug intake is again very, very important. All kind of drugs in the elderly particularly can cause falls and altered sensorium, which is episodic. Hypoglycemic episodes, I'm sure as physicians and neurologists, we are very careful about these. And then you have tonic spasms of MS, where the first presenting manifestation could be a focal spasm, as I'll show you. You can have people with segmental myoclonus, which could be thought to be an APC, and several psychiatric disorders. Second to syncope comes the psychogenic epileptic events, which is really very, very common. So there are several causes of syncope. I won't bore you with the theory slides, but this is just a rough list. And why it's important is, please take a detailed history. With abandoned, gymming nowadays, it's not uncommon for people to go to the gym and collapse, and that collapse could be transitory, hopefully not permanent, as we are seeing in some cases in the news. And this transitory collapse could get mistaken as a seizure, whereas it's a post-exercise or intra-exercise syncope. So always take the history of what the person was doing prior to the event. And then there could be cardiac sinister causes. We'll go through them. And there could be structural causes. There could be, cardiomyopathy, which hasn't been diagnosed, atrial myxoma, which is lying there. And the first manifestation is that of an altered sensorium. There could be vascular steal phenomenon, which are happening. So anybody where the episodes are not controlled and you're fairly certain this may or may not be a seizure, an ECG is warranted, though ECG, like an interictal EEG, will pick up only about 5 to 15% of your patients. You may have to go into further investigations. The common thing which we see is a prolonged QTC, and we know that the normal QT interval is less than 400 milliseconds in males and 460 in women, and anything beyond 450 should raise the flag as to whether the person could be having that particular syndrome. And look for any kind of ECG abnormalities, including that of the Brugada, where you have a partial right bundle branch block. So this is a young lady who's actually the wife of that sinking sensation used to get, isn't it? And she's come with episodes, and she was started on levetiracetam. And her episodes were typically very historically like syncope. So from the outpatient, I walked her into the tilt table, which is used for provoking the episodes. And you can see here she has the episode with asynchronous jerking of so this is what she has, hands, which is what is mistaken as seizures. So the first clue is, of course, the history, and the second is the asynchronicity of the jerks. Both the hands were shaking at different point times, and we got a positive tilt table test. And she had a QTC, which was prolonged, of 510. And of course, we got her off the levetiracetam. You can have people with PSVT presenting with altered sensorium. You could have people with cardiac asystole, which is temporary, presenting with seizure-like episodes. So this is just to show you one. You could have people who are in high-stress situations who just fall down, and there's panic all around, and nobody actually knows what's happening. And this turns out to be a highly stressful situation, which is resulting in, of course, falling down, and it's a vasovagal syncope. Sometimes we use a carotid sinus, just like the tilt table. The bedside test is, of course, a carotid sinus massage, and there's a positive response where you do it on the right side first for a minimum of 5 seconds, the massage, and you can go on to 15 seconds. So it's just the carotid sinus for 15 seconds, and you have to have the patient on a monitor preferably, or you have to have the pulse being seen and the blood pressure being seen. A positive response to the carotid sinus massage is longer than 3 seconds of asystole, which is scary, but sometimes you have to do it, particularly if the tilt table is not available and you really want to make a diagnosis. And a systolic blood pressure drop of 50 millimeter mercury or more. So it's contraindicated. Don't try to do it in patients with recent stroke or MI. Where you are not still able to make out by doing either a carotid sinus massage or a provocation by tilt table, you may have to go in for a 24-hour Holter, and sometimes even a longer duration, 72 hours to 1 week, monitoring. So what is it in the history? I keep referring the history. So history is, in a syncope, usually there will be some kind of lightheadedness. There will be a feeling of a curtain coming before the eyes. Don't mistake it for occipital lobe epilepsy. And of course, it will happen when the person is, usually upright. It will not happen when the person is supine. And usually it will be very, very brief. There may be pallor, there may be sweating, and the tonic movements or the asynchronous movements are never more prolonged than, usually never more prolonged than 15 seconds. So, and the recovery is very, very rapid. So these are features which would go in for syncope clinically. Then, of course, comes the next. So I told you syncope is the commonest. Then comes the psychogenic seizures. And for psychogenic seizures, it's very important to know that usually they want to be seen. So they may have it right in the outpatient in your room, or they will have it when they are surrounded by people whom they want to get their attention from or express their emotions in that way. And usually it never happens in sleep unless a person gets up from sleep and then has it. It usually is very prolonged. It will not be like the 2 minutes of a typical seizure. Usually associated with pelvic thrusting, vocalization, strange sounds, bizarre asynchronous flinging movements. The eyes are usually closed, and when you try to open it, there's resistance. Injuries are uncommon. Sometimes, rarely, you may get burns. You may get injuries in the shin, which are known as carpet burns. You may get a tongue bite at the tip of the tongue. So a lateral tongue bite is more for a true seizure. Rarely you can get a tip of the tongue bite. Incontinence is uncommon, but in patients who have gone untreated, we have seen incontinence as well. And sometimes you have to go in for advanced induction EEG or a video EEG to demonstrate the event. Now, so it's important to remember that try to get a home video, because home video does help in a lot of patients where the relative has captured the whole video of the event, because it's prolonged, it's easy to capture. And if you get this pelvic uplifting and you get this asynchronous movements of the limbs, that's one clue on the home video itself. And then, of course, there are certain eye signs which we want to look at. And the eye signs are very important. Ask your staff nurse or the relative whether the eyes were closed. So the eyes being closed is hugely suggestive of psychogenic seizures. And when the nurse or the clinician or anybody tries to open the eyes, there is a downward movement of the eyes, which is known as a geotropic movement. So there will be a geotropic movement of the eyes. In a truly unconscious patient, there should be a bell's. So there will be uprolled eyes. Unlike that, in a focal seizure, which is of extratemporal lobe origin, there will be version of the eyes. And in a focal seizure, which is of temporal lobe origin, the eyes will be staring or whatever. And in a syncope, there will be uprolled eyes, which is due to the altered sensorium. Now, ask your staff to look at the pupils, a reacting pupil, a plantar, which is flexor, a withdrawal, a hand over face test, where the hand does not fall on the face, it falls on the side. And of course, a mirror test where the mobile, of course, you don't have mirrors nowadays, you have mobiles. So you just bring the self camera of the mobile to the patient, and the patient has an eye-to-eye contact with the self camera of the mobile. This also suggests psychogenic seizures. So just to show you typical one, which she's just sitting there with her eyes closed and movement. So she starts with this while the history is being presented. So it's pretty simple to diagnose. Sometimes you have to get them in for monitoring, and you can see here that there is a vocalization and turning onto the stomach. That's another important sign. So sometimes if the eyes are not closed, they're turned on, they turn onto their stomach, and look at the movements of the legs. They're alternate or they are together, bizarre. So very much like psychogenic seizures. So there's a limitation of scalp EEG. If you don't do it with induction, the EEG may be abnormal in a non-sleep deprived person in only 30%. And in a sleep deprived, you may get an abnormal EEG in 80%. But for psychogenic seizures, you will have to ask for an induction EEG, and a short-term EEG does, work out too. Now, the other is, of course, the difference between migraine and epilepsy. As I told you, it's not uncommon that, both are episodic and both are common. Migraine is generally more prolonged than a seizure episode, and you rarely get any complex hallucinations in a migraine, unlike, formed hallucinations which you get from the TPO junction in an epilepsy. What is characteristic is the aura, where visual aura, which will have achromatic linear patterns as a rule in migraine with aura, and tonic deviation of the eyes, as you can see. So I'll just go through quick videos. This is a young girl who was diagnosed as having seizures and was put on 2 anti-seizure medicines, not responding, came back to us and for evaluation for drug-resistant epilepsy. And all the episodes would occur only in the night. None of them were happening while awake. So that was odd. So this is what she would do, and of course here she's under the blanket, and it doesn't look like a bicycling movement, it doesn't look like anything. She goes back to sleep, and the EEG just doesn't show anything except movement artifacts again and again. So we did a polysomnogram, full extended EEG montage, and she had these movements in sleep again, which were labeled as dyskinetic, and I don't know why it's not playing here. So you can see she's in stage 3 sleep. There are no epileptiform discharges, and the movements start off. So this case has been accepted for publication. It's a case of ADCY mutation. And guess what she responded to? She responded to caffeine. So we got her off her anti-seizure medicines, and we put her on caffeine. So that's a movement disorder, dyskinesias in sleep, which happens in ADCY, and responding to caffeine. The other common thing which gets mistaken as seizures is, of course, paroxysmal dyskinesias and dystonias. And you can see here this girl, while she's walking to the AIMS, OPD, she has this, and then it disappears also. So keep that in mind, and always think of PKD, and especially if it's occurring when the person is moving, and has never happened when the person is stationary or sleeping, and they respond to a very low dose of carbamazepine or benzodiazepines. There are other sleep activities, and I don't want to waste time. I think I have very little time. I'll tell it as I show the videos because I would rather show the videos. So here's a young man who's just been married, and I was told I could take 5 minutes more if I'm permitted. So he comes with these nocturnal jerks, which the wife can make out. And ever since the marriage, the wife is unable to cohabit in the same bed because he starts jerking in sleep. And his polysomnogram shows very frequent REM twitches, which are prolonged and sustained. And we go back to the history. It's not JME. He was diagnosed as JME initially, and he was taking valproate. He's addicted to cough syrup, and he's addicted to amitriptyline in high doses. This is the history, which the wife didn't know before marriage, and we get him off his valproate. He had drug-induced RBD, which is very common. In young people, if you get a history of RBD, which mimics seizures because there was this nocturnal jerking happening, valproate was started, thinking it's JME. Think of drug-induced RBD. Elderly man with, just bizarre movements in sleep. As you can see, the home videos are very, very useful. Muttering in sleep. So this is again RBD. It's not seizure disorder. And the diagnosis of RBD requires that a polysomnogram be done. And you can see here, during the REM phase, there is increased muscle tone, which shouldn't be happening. There should be muscle atonia, and it's there for quite sustained periods of time. This is another patient. I'll show the video later. Of course, bruxism is another common cause because they often come with teeth clenching and sometimes salivation, and you have to do a polysomnogram if the history is not forthcoming and you find these muscle artifacts happening, which diagnose bruxism. This is a child who's getting up from a cataplectic attack. So he's just fallen down. He's had cataplexy. And then he was again diagnosed as having seizures, and he was put on sodium valproate for whatever reasons. Many of these people get obese because they have narcolepsy, cataplexy, and they have obesity associated with it. He also had jaw atonia as a manifestation. As the video continues, you will see it. And he comes all the way from Gorakhpur with a diagnosis of epilepsy, which is not responding. All he has is cataplectic attacks and excessive somnolence. As you can see here, he's just dozing off again and again. This is a video courtesy Dr. Kotagal, where there is fragmentary. It's only on one side. These are more likely to get confused with seizures because they're just jerking of one side. And another patient who used to feel very happy when his wife used to cook him fish because he loved fish. Unfortunately, that fish eating was filled with such happy emotion that he would get into a cataplexy. The diagnosis is by doing a sleep study, polysomnogram with MSLT. So you have to do a nocturnal PSG followed by MSLT, which shows SOREM. So you can see these multiple sleep onset REMs occurring within 15 minutes of the sleep onset. Here the SOREM latency was really just 5 minutes. So this is diagnostic REM sleep. You can see the REM here, the rapid eye movements, along with sleep onset REM in the MSLT, which is diagnostic. Another girl with cataplexy, and we thought she has narcolepsy, cataplexy, but no narcolepsy. And then an Institute resident looked at the eye movements, and there was a restricted upgaze. And this young girl, she came with recurrent falls, and she was also on anticonvulsants. So all she had was this restricted upgaze, and she had some atrophy. She, in view of presence of cataplexy with no hypersomnolence, we got her genetic screening done, and she turned out to have Niemann-Pick's type C. So cataplexy secondary to Niemann-Pick's was there. Sleep terror is another very common cause. It can be mistaken as Rolandic epilepsy, self-limiting Rolandic epilepsy, because they usually always come from sleep. There will be sudden panic, tremendous autonomic discharge, mumble sleep, speech, and then there will be an arousal. So really it's very noisy, and sometimes they're salivating because of the autonomic activity, and they get mistaken as having seizures. Head rolling, one of our staff nurse's son, head rolling on phenytoin, was put on phenytoin, and we had to get him off his phenytoin. So you don't get him off his phenytoin without confirming the diagnosis in the sleep study. got him in, and lo and behold, he's in stage 3, and the movements start, and these are occurring at 1 per second, highly characteristic of periodic movements in sleep, suggestive of head rolling, and got him off his phenytoin. So all the PSGs which I've been doing for these differentials is essentially for getting him off their anticonvulsants. So young girl who has nocturnal episodes which are prolonged, where she gets up and starts walking around the room, more so during exams. You can see here she has frequent arousals in her stage 2 sleep. Her stage 2 is full of these arousals, and as she moves into stage 3, that's where she's getting up and walking. So that's her non-REM parasomnia, and again she was pulled off her anticonvulsants. Sleep myoclonus, again we don't do PSG unless the patient is on anticonvulsants, and here you have just the artifact which is produced by the muscle, and the PSG helps in knowing. Now, this is a complex case of OSA with pseudo RBD, where he had rolling movements on the bed and pointing movements from the fingers. He was actually labeled as complex partial seizures in those days, and we realized he's actually having hypercarbia due to severe OSA. And we put him on a CPAP, and you can see the complex, bizarre movements which are happening. And this is OSA pseudo RBD. It mimics a RBD. It's not an RBD. Due to extreme hypoxia, they have these complex movements. All they require is a CPAP titration and treatment with that. The rhythmic movements can be captured on the polysomnogram. Nocturnal paroxysmal dystonia, again a young girl. Here you can see all she has is minimal dystonia of the hand. This category came under a parasomnia before, but now has moved on to the seizure category. And you can see here the right hand is going into a posturing. She also has very frequent arousals in her polysomnogram. This is unilateral periodic leg movements. It's not unusual for unilateral periodic leg movements to get labeled as seizures, because the eyewitness will see only a fraction of the movement and will come with a history of right lower limb moving in sleep. And somebody has started, so this was a patient from Bihar, started on true anti-seizure medicines and still continuing to have rhythmic jerking in sleep. And all they had was periodic leg movements, and you pull them off their anti-seizure medicines. Similarly, another lady presenting with unilateral periodic leg movements, confirmed on polysomnogram. Here you can see the periodic leg movements. We often do extended EEG montage. This is a patient referred by Surekha. I hope she remembers, turned out to have an insulinoma. So in sleep, she would have these periodic leg movements, got labeled as frontal lobe epilepsy, and was referred. And then so all she would do is whole night she would be cycling, and this would start in the later part of the night. So by 2, 3, 4 a.m. never occur in the early part. And so she had periodic leg movements which were secondary to hypoglycemia, and we reported this case. So essentially anything which moves in sleep could get labeled as a seizure, particularly if it's unilateral. It is important to thrash out clinically whether it's happening in the initial part of sleep as the person is going to sleep, in the initial 1/3 of the sleep, in the middle 1/3 of the sleep, or the latter 1/3 of the sleep. It's important to do a PSG in select cases and monitor these patients. Last but not the least, a young doctor coming with spasms, unilateral spasms. These are spasms. This was a presenting manifestation of an NMO spectrum disorder with a demyelinating lesion in the high cervical cord, and she responded to very low doses of CBZ, of course, immunomodulation. Episodic ataxia can also mimic, so this patient was labeled as dropping down due to seizures, and all he had was episodic ataxia, so you can see broad-based, and he responded to phenytoin. Focal seizures, I had this patient who's labeled as focal seizures, started on levetiracetam, not responding, and he actually had a neuromyotonia syndrome. So essentially anything can present as seizures, and my time is up. It's important to keep the the antennae high for red flags. Wherever you are not certain, try to induce clinically, try to do a tilt table if you're thinking of a syncope, carotid sinus massage, video EEG, a PSG with EEG, and prolonged Holter monitoring if need be. And for those at high risk, wherever there is this cardiac systole happening, think of putting a pacing and managing these patients. So with this, I'd like to conclude. And once again, I thank the organizers for giving me this opportunity.
Thank you so much, Dr. Manjari. Any questions on the topics? Yes, sir.
Sir, you were mentioning also, if there are major comorbidities
You can give Dr. Gagandeep a
associated
mic.
with
No?
the status epilepticus
Mic.
or refractory or say
Yeah.
super refractory, say multiple tuberculosis, will it change or you have to add on something for this or not? Number one, or there is some different approach for it. Second is that ultimately, when do we give up? Does it come up as you were telling about describing the EG changes, and then it goes into say for alpha coma? When do we give up the treatment for status? Ultimately, as you said. Thank you.
Right. Thank you for those questions. And question about comorbidities. So if there are medical comorbidities, I would expect that the prognosis is not good, and there would be a lot of limitations to treatment. For instance, if there is some cardiac disease, I would expect that these patients are more likely to develop hypotension with thiopentone or any of the other intravenous anesthetic agents. So I think comorbidities are extremely important, and I certainly think that I think one of the status epilepticus scales, the ECME is the one which has incorporated comorbidities, and that it predicts the prognosis based on the presence or absence of comorbidities. The second point was, when do we say it is all futile? I don't think we should ever try to say it is futile. I mean, there are reports in literature, and I think we've managed status for at least more than a month, and that's I can remember. But in the literature, there would be examples of status going on for months and months together, and then eventually, and I forgot to mention surgery as one of the modalities for treatment of status epilepticus. So there are a number of reports about surgery, and I think I completely forgot to mention that. So I think the rule should be never to give up, but of course you need to look at what the overall neurological status of, because the patient often dies not because of status, but because of the underlying disease, whether it's stroke or trauma or whatever it is. And the long-term neurological prognosis is also often dictated not by status, but by the underlying condition. Thank you.
Any other queries from
Hello.
anybody?
Sir, I'm Dr. Seema, working as a neurologist in Gurgaon. I have a question for Dr. Kurian. Can you, sir, please describe the MRI findings in various metabolic encephalopathies?
MRI findings in metabolic encephalopathies is not possible to say again without coming on stage. Actually, I skipped that part because of lack of time.
Metabolic causes like toxic and metabolic causes, they will have some general rules are there. So usually toxic and metabolic causes, like I said earlier, come with symmetrical neurological deficits. So again in the MRI, there will be bilateral symmetrical lesions with restricted diffusion due to cytotoxic edema. No mass effect, no enhancement. And there are some sites in the MRI which are, if involved, will point towards a metabolic cause. So cortical gray matter, deep gray nuclei, and thalamus. If this is involved, then the outcome is poor. Patients who have involvement of periventricular white matter and corpus callosum, the outcome is good and it is possibly reversible. So these are some of the classical MRI patterns that have been described in patients with metabolic encephalopathy. So there are 9 patterns. The first is the involvement of basal ganglia and thalamus. Then you have to think of Wernicke's encephalopathy, methanol poisoning, hepatic encephalopathy, uremic encephalopathy, and carbon monoxide poison. So in Wernicke's encephalopathy, you have involvement of the thalamus, hypothalamus, the tectum, the periventricular aqueductal gray matter, and these can enhance or with contrast administration. In methanol poisoning, you have symmetrical involvement of the putamen with hemorrhagic necrosis with SWI and gradient showing microhemorrhages. In a patient with the chronic hepatic encephalopathy, you have hyperintensities in T1 sequence involving the globus pallidus, and also you can have corticospinal tract hyperintensities that you frequently associated with patients with motor neuron disease. In a patient with uremic encephalopathy, you can have flare hyperintensities affecting the white matter, and this will delineate the lendiform nucleus. So this is commonly referred to as the lendiform fork sign. In a patient with carbon monoxide poisoning, in the initial stage, you can have a hemorrhagic change involving the bilateral globus pallidus, and in the subacute phase, you will have an acute toxic leukoencephalopathy picture with hyperintensities involving the white matter. The second pattern in metabolic encephalopathy is a dentate nucleus involvement, which is seen in patients who have been administered metronidazole for longer periods. And then you have the prominent cortical involvement of the gray matter, which is again symmetrical, which you get in patients with hypoglycemia and in patients with hyperammonemia. So this is a patient who has been administered metronidazole, and there is hyperintensity involving the dentate nucleus. Here you have a patient who has had hypoglycemia for a long period. In addition to the cortex, you can see that the gray matter nuclei are affected. So again, the prognosis is poor, like we discussed earlier, the cortical gray matter and the gray matter nuclei. This is a patient with hyperammonic encephalopathy. So it almost looks like a CJD picture where you have bilateral symmetric diffusion restriction, but here it is involving the insular and cingulate gyrus, sparing the parieto-occipital region. You can have an acute toxic leukoencephalopathy picture with symmetrical white matter changes. This is seen in inhaled heroin toxicity, methotrexate toxicity, and in carbon monoxide poisoning in a subacute stage. Here it is white matter involvement, and if managed properly, it is completely reversible. So this is a patient with inhaled heroin toxicity who has symmetrical bilateral periventricular hyperintensities. Corticospinal tract hyperintensity. This might be seen in patients with vitamin B12 deficiency and in patients with chronic hepatic encephalopathy. In addition to the T1 hyperintensity in globus pallidus, you should look for corticospinal tract hyperintensity. Corpus callosum involvement is important. I earlier said that corpus callosum involvement is reversible and indicates a good prognosis, but that is not the case in patients with Marshavavi-Bignami disease, where you have hemorrhagic necrosis of the corpus callosum. Here you can see a patient with the history of binge drinking who presented with apraxia and hemialexia. There is a demyelination and necrosis of the central portion of the splenium of the corpus callosum. This is sandwiched between normal areas, so this is called a sandwich sign, and it has poor prognosis. Patient will have the seizures and encephalopathy. This is the MRI picture of a corpus callosum involvement with the reversibility, but this patient is unlikely to present to you with altered sensorium. Usually with anti-epileptic withdrawal or in a patient with viral encephalitis, you will have a reversible splenial hyperintensity. So the patient will usually be normal and the MRI only will pick this up. You can have an asymmetrical symmetrical parieto-occipital subcortical vasogenic edema in a patient with PRES. There will not be any diffusion restriction. It can happen in atypical cases, but usually flare hyperintensities symmetrically affecting the parieto-occipital white matter. That is typical of PRES, which is seen in patients with accelerated hypertension and after some chemotherapeutic agents. Again, the well-known symmetrical central pontine involvement in osmotic demyelination syndromes. Here you have the typical trident-shaped lesion. It affects the dorsal pons and the central. Usually, at least in the initial cases, the region of the corticospinal tract will be spared. So, I think that covers the MRI findings in patients with metabolic and toxic derangements.
Thank you, Dr. Kurian. I think if there are no more questions, we can conclude the session. I thank Dr. Manjari Tripathi, ma'am, Dr. Gagandeep sir, and Dr. Kurian. Thank you.
I thank all our esteemed panelists and speakers of the 3 pre-lunch sessions for taking time out of their busy schedules to teach us such important, vast and complicated topics of neurology and elucidating these topics for us. Our post-lunch session will start from 2:45 p.m. in the same Hall A, and all faculty and students are invited for lunch in the exhibition area and pre-function area and may proceed for same. Thank you.